Okay. Welcome to the Board of Health meeting. Chairman Kelly is out this week, so you're stuck with me. When we put this agenda together, I tried to keep it fairly light. We've had a lot of conversation in the past months on suicides and different things, and the 988 number keeps coming up, and Great Rivers Behavioral Health was in and chatted with us about the coming 988 and their current line and stuff. And I thought it'd be good information for you to hear as to what they're working on. So we reached out to Trinidad, and he was gracious enough to come in today and kind of go talk over what they talked about with us and what their plans are and how we can support their plans. We sent a letter of recommendation to support that, and maybe there's something that the public can do also. So if you want to, however many want to get it to Mike's, we'll turn over and let you. We got two over there and we have one here. Okay.
Good morning, Commissioners and Board of Health. Thank you for having us. My name is Trinidad Medina. I'm the Chief Executive Director with Great Rivers Behavioral Health Administrative Service Organization. We are charged with ensuring that our 5-county region has access to crisis services, which includes a regional crisis line, mobile crisis response, boots on the ground out, being dispatched out into the community, and designated crisis responders, which are the folks that can go out and involuntarily detain individuals in the community. Okay, I move that up. Sorry about that. So we also administer other funding, federal block grant funding, and operationalize legislatively directed programs like the Recovery Navigator program. So our 5-county region includes Cowlitz, Wahkiakum, Pacific, Grays Harbor, and Lewis counties. So we're here today to share some information with you all about our regional crisis line change that just recently occurred, and some information, and share some information related to 988 and the future of crisis services in Washington State. So I'll go ahead and hand it over to we do have a slide deck, so I don't know if we could pull that up. And I think we're on slide 2 now. And what we'll do is we'll just go down and introduce ourselves. And we have a team here from 3 different organizations. So Andy, would you like to introduce yourself?
Thank you. Good morning. My name is Mandy Moore, and I'm part of the clinical team at Great Rivers BHASO.
Good morning, Commissioners. My name is Joe Avalos. I'm the Executive Director for Olympic Health and Recovery Services, and we are the not-for-profit behavioral health agency that just took over the Great Rivers Regional Crisis Line. So thank you for having us.
Good morning. My name is Drew McDaniel, and I am the CEO for Columbia Wellness. Can I jump in?
Yep, just jump right in.
Okay, here we go. So Columbia Wellness has been part of our community for just over 76 years. It began as a service for children and families in the 70s and 80s as state hospitals opened their doors and sent chronically mentally ill individuals back to the communities. We found a lot of them resided on the streets and were in need of care. So Columbia Wellness expanded to serve all populations of individuals with behavioral health illness. Going back in time, 1974, the federal government said to the states, find a way to provide for the emergent behavioral health needs of your citizens. Washington State, like all states, looked around the nation, found a model in Illinois, which they thought was a good model. brought it back, made some modifications, and since 1974, that model has included a couple of different components that you've heard Trinidad speak of. One of them being a crisis hotline, 24-hour-a-day crisis hotline. Other being boots on the ground, mobile crisis teams that can go out and provide support and intervention. And then thirdly, groups that can go out and, if necessary, suspend civil liberties and place someone in a hospital for care for potential danger to self, others, or what's called grave disability. Columbia Wellness, since 1974, has maintained the crisis hotline and has maintained the boots on the ground. For many years, we were also the entity that went out and placed individuals in care against their will if necessary. But recently, there have been some changes at the state level regarding the crisis delivery system across our great state. And Columbia Wellness was at a crossroad. Do we become a 988 hub, which we'll be talking about 988 here today, and accept all that comes with that, which includes taking calls from outside of our region? Or do we focus on our region and put boots on the ground and be there when our community needs us? And we felt that the latter was our preferred route. We were born in Cowlitz County. We've expanded to our 5-county family region. We want to stay right here and do the best we can in our community. So we reached out to the ASO and to our community partners and said, can we look at how the system is redesigning itself and how we can take control of that in our region to the best extent possible to provide the best care? So we are here to do the job and do it alongside other professionals who have the best interest of our citizens always at heart.
Thank you, Drew. Next slide, please. So transition of the Behavioral Health Regional Crisis Line took place on April 1st. So it hasn't even been a full month since Olympic Health and Recovery Services has began taking calls as the call operators in our region. As Drew pointed out, Columbia Wellness had done a fantastic job for a long time, and we really appreciate the service to the community. And with the notice, we re-procured the service and selected Olympic Health and Recovery Services, who was already familiar with our region. Great Rivers believes in, building on what we already have and utilizing the knowledge about our region, our rural region, to its fullest extent. And Olympic Health and Recovery Services began taking calls April 1st. We tested it that morning. I called at 9 a.m. and someone from Olympic Health and Recovery Services answered the phone. So we're excited to have a new chapter in our regional crisis line with Olympic Health and Recovery Services being that provider. And I'd like to hand it over to Joe for some information about Olympic Health and Recovery Services.
Thank you, Trinidad. And so, yes, we have been working in the Great Rivers region since 2018 when we assumed the designated crisis responder services. So these are the individuals that Drew mentioned that can detain somebody if they are a danger to self or others, or if they're gravely disabled due to their behavioral health condition. And so we're very familiar with the hospitals, law enforcement, all of the resources, the crisis teams all throughout the Great Rivers region. And, have been working very, for the last 7 years to really familiarize ourselves with the unique nature of each of the counties in the Great Rivers region. So we are very tied to that. And, obviously working very closely with Drew's teams and the other crisis responders with the regional crisis line when Columbia Wellness decided to focus on mobile crisis teams. And I know you're going to talk about endorsed teams a little bit later. Of course, we absolutely support that. But our biggest concern, I guess, is about what's coming on a national trend with 988 and the what may happen in making this more of a statewide or national service and potentially losing the regional aspect and familiarization that is so necessary in every county in the Great Rivers region. We'd also been providing regional crisis line services in Thurston Mason counties. So we saw this as an opportunity to, continue to provide regionalized service, and while at the same time putting ourselves in the position to potentially become a 988 hub. As we're going to talk about a little bit later, that is coming open, I believe next week? And so we've gone through all of the processes to be able to put ourselves in a position to become a 988 hub for the Thurston Mason and Great Rivers region, keeping more as regional and local control and influence on how we dispatch mobile crisis, how we refer to the local resources, hospitals, law enforcement, and just try and keep it as regional as we can. Are you going to talk about VOA later? Okay. I think we're going to talk a little bit later about where 988 stands now, but as of next week, we'll be throwing our hat in the ring to become a 988 provider for the region. So, and I do want to thank you explicitly for your letter of support in our attempt to do that, sir.
That's what I was going to say. That was our letter of support.
Yep.
We wanted to keep it regional here
Absolutely.
instead of somebody in Colorado or somebody else
That's right.
answering the phone.
That's right. And I do want to say all of our staff are, they're local. They're from Cowlitz County. They are from Lewis County. We try and hire as local as possible. Just they're staff that know their area as needed. So happy to answer any questions.
I thought, you talked about when you tested and you called and you got a live person. I thought, the demonstration of the call to 988 where you got a phone tree versus the demonstration to our local, crisis line number where you actually, a person answered the phone and was ready to talk to you. That was, to me, that was pretty huge.
So that was extremely important to us. And again, a huge shout out to Drew's team for being able to answer all the calls and most of the calls, like 99%, 98 to 99% of the time within 3 rings. So that's a huge achievement that we wouldn't see at a more global level with 988 being a national company or, an operator that from a different state. So we're just very proud of that. And one of the only ASOs that has that. We did implement one change where there's just a notice that an individual has called our line. So it says you've called the Great Rivers Regional Crisis Line, and then someone answers. But there is no phone tree. There's nothing that anyone has to press 1 or 2 or 3 or anything like that. So we're very proud of that in our service array.
All right, so over these next several slides, I'm going to briefly touch on our current crisis system design and then move into future state alignment of crisis services with 988. So within the current crisis system design, the help seeker, there is overlap for crisis services for the help seeker. They can call either the regional crisis line or 988 suicide and crisis lifeline. And both services will provide a telephone crisis intervention. If 988 deems an outreach is indicated, 988 will then contact the regional crisis line to dispatch a local mobile crisis team. And so, again, both services do provide those de-escalation services. However, like we said, the regional crisis line is local, it's community-based, whereas 988, we currently contract with Volunteers of America. They're located in Everett. They oversee the Great Rivers region as well as 27 other counties. And so, again, yes, we're really advocating for OHRS to be that potential 4th hub. There are currently 3 988 hubs throughout the state, and OHRS, yes, is going to be applying for that 4th hub position coming up next week. Next slide. So Bill 1477 is concerned with the crisis system redesign in alignment with 988. And last fall, the Department of Health and Healthcare Authority released a joint policy statement to more clearly outline what this alignment with 988 will look like. So within the policy statement, they identified that 988 Suicide and Crisis Lifeline will become the primary entry point for crisis services for the public. So again, 988 is for the help seeker. So professionals like emergency department social workers, first responders, and community behavioral health professionals will still be able to contact the regional crisis line directly for that professional consultation or for dispatch of a mobile crisis team in the community. So essentially, the regional crisis line will be shifting their focus to the deployment of in-person responses and consultation for professionals. And the help seekers who used to call the regional crisis line will be encouraged to call 988 as that primary front door for crisis support.
And I personally like the idea of calling 988. I mean, that's an easy number that we all can remember, right? I don't know if you remember the 1-800, that number that was listed up there, but that's not an easy number to remember unless you have it saved in your phone. You have to go find it, or you have to be familiar with it, or somebody needs to assist you with that. So the future state of 988 and how services are dispatched, it makes sense for our community members, you all, to just pick up the phone and dial 988, similar to what we do with 911. It makes sense. It's just an easier number, and I think that will improve access to services as well.
Yeah.
So I just
I
wanted
don't
to.
I don't disagree with that. I do want to point out on the old number, and correct me if I'm wrong, but I thought last time you mentioned like 4,000 calls a month. Is that correct? So even on the more difficult number, there's a pretty big demand out there in the 5-county area.
Right. Yeah, our call center, on average had approximately 4,000 calls a month. That is a large volume. And it was important for us as through this transition not to change that number. So we kept that number. That's the same number that's been in place for many years. And those calls are just now going to Olympic Health and Recovery Services. So yeah, we're looking forward to analyzing the data after this first month of operations and look at where we can continue to make improvements to the system.
Trinidad, if we become the regional hub for the 988, that's going to increase the call volume because I think you mentioned another couple of counties that would be involved in that. Are we still looking to provide, I'm assuming the same service where they're going to get a person, not a phone tree? And what are we doing to accommodate for that increased volume?
So currently, and I think the last set of calls that we recorded from the 988 line for March and February was right around 400 calls a month. 9 of which got transferred to our regional crisis line. So the volume isn't quite there yet. So with 988 being marketed more to the community, being that easy phone number to remember for people to call, we'll see that volume increase. I think that having a vertically integrated system with our regional crisis line and 988, providing that service, they'll be able to provide more streamlined dispatches out into the community when necessary. It will be 2 separate staff. Department of Health is the contract holder for the 988 hubs, so they contract out that service. That will not go through the ASO at this time. Department of Health will be the entity responsible for overseeing that. And at this time, we, as ASOs, have an opportunity to make a recommendation and participate in work groups with Department of Health and the Healthcare Authority. But the ultimate decision makers around how that contract is and what those expectations are is Department of Health. So I think to our benefit, we'll have an ability to have a vertically integrated system if Olympic Health and Recovery Services is successful in that application process.
And that's the State Department of Health?
Yes, Washington State Department of Health.
I'm sure they're going to fund that properly. Right? I'm sure the state will adequately fund that and not require counties to do it.
Yeah, well, a lot of the 988 funding comes from a cell phone tax. We are all currently being taxed, 988 tax. So if you look at your cell phone bill, you will see that tax. All of that tax revenue is used to fund the 988 hubs and some mobile crisis response.
And I believe the current 988 hubs outside of VOA are vertically integrated with regional crisis lines as well. Mhm.
Yeah, there's 10 ASO regions in the state of Washington. And most of them are already vertically integrated. Great Rivers and Thurston Mason is unique at this time, where we have a different regional crisis line operator than the 988 hub operators.
So Bill 6251 was also concerned with crisis system redesign. And within that bill, they tasked the ASOs with convening stakeholders throughout the region to talk about our regional dispatch protocols and bring in 988 to develop and formalize protocols in alignment with this future state alignment with 988. So throughout that work group, we created the 988 and Regional Crisis Line Transition Timeline for 2025. And I'm not going to touch on all the points on here. We did already cover some of them. The first one is that our new Regional Crisis Line provider, OHRS, became operational on April 1st. And then next week, at the end of Q2, the 988 hub applications will open. So as it was mentioned before, 988 receives around 300 to 400 calls per month for our region, whereas the Regional Crisis Line receives around 3,500 to 4,000 calls a month. So as you can see in the timeline, we are going to start ramping up 988 community education closer to the beginning of Q4 of this year to ensure that 988 hubs will be able to handle that additional call volume once 988 hub designation is complete by the end of the year. So beginning in 2026, we should have our 4th hub designated for the state. Next, do you want to add something else?
Yeah, I'd like to. Well, once again, thank you for your letter of support. We do have another version of that letter of support that we can share out for community partners who would also like to support Olympic Health and Recovery Services application. We could include that in the meeting documents, so save it to your records so that the community can.
So if the community
access that.
wanted to support this idea, you have a version that they could submit to this
Exactly, yes.
also, okay.
Yes, and I'd like to take this opportunity to also kind of just share an example of why it's important for our local dispatching team or local crisis teams to provide that full array of service, the regional crisis line, mobile crisis response, and DCR services. And I'd like to ask Drew to share an example of a case that was eye-opening when I first heard it. Drew?
Certainly. So Columbia Wellness, as I said, has been in our community about 76 years. I'm the old guy there. I've been there almost 31 years. And I've had the opportunity to run most all of the programs except our medical team, not that qualified. But when I ran the crisis team, one of my favorite, I guess you can call it patients, consumers, person in need, was an older lady who called us whenever she was out of milk. And, you know, as clinicians, we understand the importance of trauma-informed care and how different people respond to trauma and how you can help them cope and adjust with that trauma. We firmly believe in regionally informed care, culturally informed care. Those are truths, realities that we deal with, especially in small rural communities. And so when she called and she was out of milk, we all put together our dollars and our quarters and went and got her 3 or 4 gallons of milk and took it to her home. Made sure she was okay. The story behind the story was that this individual suffered from extreme gastrointestinal reflux. Whenever she had that, milk was her go-to. Without the milk, it got worse. It increased in severity. That triggered anxiety. The anxiety triggered a psychosis. Her official diagnosis was schizophrenia, paranoid type with psychotic features. She had been on the psychiatric unit many times at Peace Health. She had been at Western State Hospital many times, trying to recompensate from a level of severe deterioration. So if going to get a few gallons of milk was going to help her, doggone it, that's what we're going to do. And I look at that example, and as you've heard, when the state opens the procurement process for that fourth potential hub, 988 is a national, it is a federal program. There are hubs all across the United States. There's hubs in Colorado. They're one of the largest, and they're quite interested in moving into Washington. There's hubs in New York. I always think of the salsa commercial. New York City. I can just imagine someone from our community getting someone from New York City saying, I'm out of milk. I want people to define their own crisis. We all have that right. And in our community, let's keep the service regional, cultural, local as much as possible, because we can look out for one another, and that's important to us.
Thank you for sharing that story, Drew.
All right, so moving on, briefly talk about when you would call 988, the regional crisis line. And then I'd like to touch on our mobile crisis response endorsement program. And so the question is, when would you call 988? And the answer is when you or someone you care about is seeking help for a behavioral health emergency. So again, 988 is for the help seeker. And the Suicide and Crisis Lifeline will be that primary entry point for the public. So 988 counselors are skilled in de-escalation and crisis support, and they'll be able to work with the help seeker to identify their needs or the need for dispatch for a local mobile crisis team to go out and provide some additional in-person support. Next slide. As Trinidad mentioned earlier, 988 is an easy to remember number. And the goal of 988 is to provide immediate crisis stabilizing care in the least intrusive manner possible. Something that community members have shared is that they really appreciate the anonymity with 988. You don't have to give a lot of personal information to talk about your presenting issue, the crisis that you're currently experiencing. And so for the majority of people who are calling in for support, 988 will be able to provide the appropriate intervention. However, again, if there is a presenting need, 988 does connect with our mobile crisis, with our regional crisis line, so that our regional crisis line can dispatch a mobile crisis team to the person in need. And another goal of 988, I think, is to divert some of those behavioral health crisis calls away from 911, so that 911 can also be responding to more appropriate calls. Next slide. So again, an individual will still call 911 when there is the need for immediate containment. And this is when an individual is perceiving risk or danger to their self, their property, or their environment, or when there is any medical emergency, or really anytime the caller believes an urgent response by law enforcement or emergency medical professionals is needed. So the 911 State Coordination Office is also working with 988 to develop protocols for 911 dispatchers to follow, so that if they believe that there's a behavioral health crisis happening, that they can call either 988 or the regional crisis line for that in-person support. Next slide. So again, the regional crisis line will be shifting their focus from being that first line of intervention for the person in need, for the help seeker, to being more of a professional consultation line. So the line should be used for community professionals seeking consultation, those entities seeking a DCR evaluation, individuals who are currently receiving crisis stabilization services. And this will leave 988 call clinicians more available to help seekers in emergent need who need that immediate support over the phone. And the regional crisis line number, however, is not changing. And so moving forward, as far as we can tell, we're able to keep the 1-800-803-8833 number. And so in the event that an individual does happen to call the regional crisis line instead of 988, they won't be turned away. So there's still a no wrong door policy. We want to be able to serve the individual as quickly as possible. And that doesn't mean connecting them back to 988 if they just happen to call the wrong number. Next slide. So again, who should be calling the regional crisis line? And these will be professionals like 911 and 988, first responders, law enforcement and corrections officers, hospitals and medical providers, behavioral health providers, schools, and those individuals who are currently receiving crisis stabilization services through a mobile crisis team. Next slide. So before I move into future state alignment, quick snapshot there, I wanted to touch on the Mobile Crisis Response Endorsement Program. So Bill 1134 passed in 2023 in response to the need for more accessible and effective behavioral health emergency services within our state. This also created the language for the endorsement standards for our crisis teams. So the goal of this program is to enhance the statewide behavioral health crisis response system and ensure individuals experiencing a crisis have quick and easy access to help in their regions. So this endorsement for our crisis teams is a voluntary credential that, again, our crisis teams or community-based crisis teams may obtain. And our crisis teams have to meet specific response times as well as staffing criteria to maintain endorsement with the state. And there are, I believe, 8 teams that applied with the state to be an endorsed team. And we have 2 of those 8 in our region. One of them being Columbia Wellness here, and the other one as Cascade Community Healthcare in Lewis County. And so both teams have met the initial compliance requirements, which is great, with the goal of becoming fully endorsed by July 1st of 2025. I don't know if you wanted to add anything else to that.
Yeah, thank you, Mandy. So as the ASO for our region, it was important for us to engage in discussions early on with our mobile crisis teams to really help facilitate the process of getting endorsed. Columbia Wellness has done a fantastic job meeting all the requirements, sending in policies and procedures, and working with us as we were learning about the endorsement requirements and what the healthcare authority was going to require of us. We're still working on this process, but we're very excited that Columbia Wellness was able to achieve that initial approval. And I'd like to hand it over to Drew if there's anything you'd like to add about the work that you're doing and kind of where you're at. But
Yeah.
For Great Rivers, we are in full support of that endorsement and continue working with Columbia Wellness to ensure that they are endorsed by July.
So Columbia Wellness is part of a statewide behavioral health group that does our best to be aware of legislation that's coming and how to influence it to meet our community needs. And I remember attending one of those meetings about 6 months ago. And the hot topic was, are you going to become an endorsed mobile crisis team? And I remember saying, yeah, that's the highest level. We want to go for that. And I remember other organizations defending why they couldn't become one. And I found that odd. If you look at the endorsed level, they're basically, if you look at a stool with the 3 legs, endorsed teams have more training. They have higher levels of training than other community-based mobile crisis teams. Why do you need more training? Well, to do a better job. Heck yeah, we're going to get more training. Number two, they have increased staffing levels to include certified peer counselors who can help. I remember I asked one, a substance use peer counselor one time, what is your role? And he said, look at the docs over there. He goes, when they detox them from the med or the drug, my job is to detox them from the lifestyle. I thought that was a beautiful statement. Let's have certified peer counselors come in and be a part of this mobile crisis team. That's the second leg, the staffing model. The third is, as you've heard, is to be able to get out into the community. The standard that endorsed teams must meet this year is from the call request to the moment we're out the door is 20 minutes or less. In 26, it's going to go to 15 minutes or less. Currently, while triaging 4,000 calls, my team gets out within 35 minutes or less. You take away those 4,000 calls and give them to a community partner, we can get out the door within 20 minutes or less. So we decided, why not? That is our standard. It's a standard, again, that our communities deserve, our people deserve, our providers deserve. When 911 is standing there with a person on the side of the street that's in a behavioral health crisis, get your team out to be helpful and get them out quickly. And that is the role of the endorsed team. And we're glad that we are going to be one of them.
Thank you. And so the goal with this crisis system redesign for the state is to really fine tune the role of each program and ensure that there is a specific scope that they're falling within. And so within the future state alignment, the help seeker will be calling 988 for that initial crisis intervention. And 988 will do their best to de-escalate the situation and provide support. Again, however, if an in-person response is needed, they'll be able to call the regional crisis line, who can then dispatch a local mobile crisis team to the area. So again, 988 will be used for that primary crisis intervention. Then you have the regional crisis line, who will do the professional consultation or deployment of a mobile crisis team. And then the mobile crisis teams, who are going to be able to respond faster and have more wraparound support for individuals, including those certified peers. And so hopefully this will help streamline our services and make our crisis services more effective throughout the region. And with that, I'll turn it back over to Trinidad.
Thank you, Mandy. Next slide, please. Just some key organizations within our behavioral health crisis network. We as the ASO provide the funding and oversight for the services. Columbia Wellness is the boots on the ground service provider, responding out into the community in Grays Harbor, Cowlitz, and Wahkiakum counties. Cascade Community Healthcare is our boots on the ground mobile crisis team responding in Lewis County. Olympic Health and Recovery Services is the designated crisis responder organization that goes out throughout all of our 5 counties. So they're already familiar with the terrain and landscape of our beautiful region. And then Willapa Behavioral Health is in Pacific County. So they are the boots on the ground. So if you're ever in Pacific County, out on the beach or visiting family and friends out there, Willapa Behavioral Health is there if anyone's in crisis. And then our 988 operator, which is currently operated by Volunteers of America, again, based out of Everett and contracted directly with the Washington State Department of Health, which again, we're hoping that Olympic Health and Recovery Services is that organization. Next slide, please. And just some contact information for you all. If you'd like to ask more questions or think about questions later, we're happy to take any of the questions via email or phone call. And I think that concludes our slides. I think we have one more just to thank you all very much for your time. And we're happy to take questions now if you have them.
Appreciate you coming.
Trinidad, could you just real quickly explain to everybody what an ASO is, what that stands for?
An ASO, it's an administrative service organization. We are charged with ensuring that that our region, the Great Rivers region, a five-county region, has a behavioral health crisis network. We have operationalized other legislatively directed programs like the Recovery Navigator program and the Youth Navigator program, which just got implemented in Cowlitz County ahead of schedule and doing well. And we also administer federal block grant dollars for behavioral health services.
Yeah, I was just gonna mention that with the Navigator programs, I spoke to a couple law enforcement last week at the meeting that we had, and a lot of them were very grateful and they really like that program for their municipalities.
Yeah, that's been a very successful program. Operationalizing it has taken some time, but we've gotten to the point where we have now a great community partner providing the service, Destination Hope and Recovery Services, out in the community with outreach and engagement workers that really assist alongside law enforcement with individuals with substance use disorder needs.
Well,
Well, first of all, I think it's totally awesome, and I really appreciate what you're offering the community. I have two questions on, does it have to be a crisis like right now, if it's not taken care of, there's going to be a major problem? It has to be an immediate problem and not a long-term, and I'll get to why in a minute. And also, do you have to be the one that needs the help, or you're a person that you're involved with, I guess? The reason being, and I need to ask this, we have a very well-known person in Castle Rock, bless his heart. He sleeps on the corner of our freeway entrance constantly, no matter what the weather. We have offered him help. Our church has offered him help. Remember when we had this tremendous storm? He was out there, and he won't come in. Now, you made the mention of involuntary, but we're not related. He's not a friend. I mean, can I call, I mean, is this considered a crisis?
I'll start and then I think I think that would totally be appropriate to call the regional crisis line
Okay.
for that, to share that concern. We speak to family members all the time, concerned citizens, and then it's our job on our end to work with Drew's team. Hey, this is a call that we got. What do you think? Is this somebody that you know? And somebody that your mobile crisis team might want to go and see? And then Drew would.
Absolutely. I've always trained my team with the following example, that there's a continuum of care from the least intrusive to the most. And I think we all acknowledge this with ourselves. If I go see my doctor and I say, hey, Dr. Canada, I've had some headaches. Can you help me? And she gets on her phone and says, yeah, I need to schedule brain surgery stat. I'm probably going to pass out. And when I wake up, think, seriously, you're just going to go there first? How about some test or a pill or something?
Yeah.
We all deserve this. So the very least intrusive intervention is to get some boots on the ground, some collaboration, talk with the community, talk with the concerned persons calling, talk with the patient, see what we can do to help. And many times that approach of how can we help you will be effective. Sometimes it won't. And that leads us to a more intrusive intervention. And that more intrusive intervention can go all the way up to the designated crisis responder that can remove or suspend civil liberties and place a person in a hospital for care. I will say that there is a frustrating point for those who care, for communities, and for those who implement the law. The Involuntary Treatment Act law does not give us the authority to dictate quality of life to someone.
Oh,
And that can be hard, especially when the person you're calling about is someone you know and care about. The law says that there must be an element of danger and risk. And so danger and risk will be a key element that Joe's team will be looking at. But we look at that again as the last resort. There's a menu of options that we can choose, or at least try to choose from before we ever get there. So yes, that would be a beautifully appropriate call to make.
Oh, thank you so much, because we've watched him in the absolute worst weather.
Mhm.
Then you can, I mean, we've had some pretty, and he's there sleeping on the corner. And we've, please come, we have beds, will not. And we've, people have given him food. And the last downpour that we had, he did take an umbrella, and but then he chucked it somewhere. I saw him walking over the Cowlitz Bridge in Castle Rock today, and he had his blanket. He must have gotten irritated because he sometimes goes to Four Corners. He has his big blanket on, and he was trudging across the bridge. This man, I can't describe how forlorn he looks. And knowing he doesn't go anywhere but this cement, even in the coldest situation that we had, that was his bed, and it just tears you apart. So thank you. I will call.
I do have a question with regards to the suspension of civil liberties. Does the affected individual, is there any due process that they get? Because I would imagine that sometimes timing is an issue. Is there a warrant that has to be issued, or does that legislation just allow you to take it and do what you have to do?
I'll start.
Yeah,
Amanda.
go, sure.
Okay. So again, this was part of the model that came from Illinois that was modified to Washington State. Every state will have a different model. But in our model, there are two groups of individuals who have been given the authority to suspend civil liberties. Now let's look at that phrase. People have died to protect our rights and our civil liberties. So the first thing is that the DCRs must take this very seriously. We have rights in our world. Wonderful. Hallelujah. I'm glad we do. The two entities that can go in and temporarily suspend civil liberties and say to a person, you cannot go where you want to go. You cannot walk away. You cannot leave. You will be taken and placed. Are peace officers and designated crisis responders, DCRs. That's it. Those are the two entities. And the DCR's responsibility is to take all available information, lay eyes on, do what they can to see, is this absolutely necessary? Or do we have less restrictive options? Less restrictive meaning less restrictive than involuntary inpatient care. But if a person is detained by the DCR, there is a clock that starts ticking. And if the treating physician wants to continue holding them for involuntary care, then a superior court judge gets involved. There is a defense attorney assigned, a prosecuting attorney assigned. There's a court clerk that oversees that process. There's an official hearing that takes place and an official court-ordered finding of fact as a result of that. So there is judicial oversight, and the state of Washington ensures that. If you go to state hospitals across the United States, most of them have graveyards attached. It's unfortunate, but up until the 80s or 90s, if you ended up in a state hospital, you could almost rest assured you were going to stay there. And many people died in state hospital care because of old age. And they're buried in those grave sites. The state of Washington wanted to ensure that that would never happen. And so there is regular judicial oversight with hearings.
You use the word peace officer. Could you define that? Because in my mind, there's a difference between law enforcement and a peace officer based on how they view their role and enforcing that role. So is there a difference can you define what a peace officer is and what with your explanation there?
Yeah, go ahead. I think you mean.
So Washington State has two definitions. There's a limited authority and a full authority peace officer. The state has not made a difference or a differential decision as to whether you can be limited authority or full authority that I'm aware of. Do you know anything to the alternative? So anybody that the state has designated or ordained as limited authority peace officer or full authority peace officer can take a person into custody. Now, if you ask me more than that, I can't answer it.
And I think I'll just add that the DCR holder, the detainment is up to 5 days, not including weekends. But at any point during that placement, so there are a lot of steps that have to be involved in order for somebody to officially be detained or placed. The facility where they're placed, whether that's St. John's or Telecare or any facility that's licensed to do that, they can release that hold at any point. And so
Based on their own assessment.
based on their own assessment and how they feel the patient is doing. So while there is the court process that occurs after that, after those 5 days, I don't know the numbers for Great Rivers, but I would say it's probably close to 40 to 50% that don't ever make it to a court hearing. They're released within those 5 days, 5 to 7 days or so.
So I was listening for trying to hear a definitive answer of, is every law enforcement officer a peace officer?
I would, at this point, if you're including, for example, Department of Corrections, a corrections officer, DOC officer, they are not. They're typically assigned to a local police department or a county sheriff department. Those are the two that historically we've always worked with. So Calais County Sheriffs, Longview, Kelso, Kalama, Woodland, Castle Rock.
Okay.
I just find it interesting that you use the word peace officer, not law enforcement, because in my mind, like I said, depending on how they execute their role and how they view their role, there is a difference to me.
There is, and the peace officer language is directly from the revised code of Washington, the 7105 and 134. It does not refer to them as law enforcement officers. It does designate as peace officer. And when you look at the definition, it's the limited or full authority.
Okay. Any other questions from board out here?
You mentioned the three key words, all available information. So throughout, whether it's city, state, county, whatever the region is, there's new cases, but many of them are repeat cases. People are looking for information on a repeat. So how is that information gathered and how is that information available to service agencies or even to family or whatever?
Do you mean on callers that are repeat callers and potentially folks that we would need to see multiple times? That happens quite a bit. And that actually speaks to, I think, the justification for vertical integration between the 988 provider and the regional crisis line. You're right. There are a lot of repeat callers. There are a lot of callers that call either 988 or the regional crisis line for either for their family members that we need to see multiple times or that we need to refer to Drew's teams multiple times. The 988 and RCL call takers who are in the best case scenario vertically integrated will have access to the information that we've got in our electronic health record about what has occurred in previous call attempts or how many times we've sent out mobile crisis team or had to call 911. All that history will be present to help in determining what's the least restrictive option to help this person get to where they need to be next.
Well, let's just go back to the lady that just needs some milk. So if she's got a crisis situation and it's occurred many times, but she can't really respond to her situation, somebody, officer, let's say it's just a local police officer shows up, how does he know that she just needs milk?
Certainly. So we've all heard of the federal HIPAA confidentiality guidelines.
Correct.
42 CFR. There's a phrase that I've always trained my staff on, and it's actually a phrase that I stole from Judge Michael Evans, that when risk or potential danger is perceived, confidentiality begins to evaporate. And I love that phrase. It doesn't completely disappear, but it evaporates enough for a person to be able to help someone do their job. So if law enforcement called us and they're out with Jane, we'll call her Jane, and they're in the middle of a crisis with her, what can you give me? We're going to be able to help release enough information in that crisis to be helpful to that officer and to that patient. We can't go into the full detailed history, as it doesn't evaporate completely, but it is enough for us to be helpful. And I think that is the understanding and the key regarding a partnership, a regional local partnership, is because we'll know, hey, it's Olympic Health calling. Let's open up our file, see what we can offer.
And just to add to that, we focus on trying to provide an intervention service at the time the individual needs it. And throughout our whole process, whether the call comes in from a regional crisis line or directly to the mobile crisis team or to the DCR, one of the things that we do well in our region is those handoffs between the organizations. There's a communication from the regional crisis line when they're going to go out to dispatch or provide information to the mobile crisis team or boots on the ground that's going to go out into the community. There's that handoff of information to assist with that dispatch so that individual is safe, or maybe they need to call in law enforcement. There's that transfer of information. If it gets to the point where there's a DCR involved, the DCR will do their work, connect with the mobile crisis team if they've been involved, and learn some of that history. So there is that knowledge sharing within our network.
I can give you a great example of a time that it worked beautifully. And this was a few years back. I received a call from Chief Huda with Longview Police Department. Said, Drew, I need to notify you. We just got a call from Bob's Sporting Goods that client so-and-so just attempted to purchase a firearm. Now, one of the things that happens on the federal and state level, there's what's called qualifying events. A commitment by a judge for a behavioral health need is a qualifying event. If we look at that hearing that we described earlier, where there's the Superior Court clerk, the Superior Court judge, prosecuting defense, all this, court clerk, if the judge issues a commitment order, every court clerk has as a database that they go and they enter that commitment order, because it becomes what's called a qualifying event, immediately after the court hearing. At midnight every night across the nation, that database feeds into the federal, what's called NICS database. This NICS database is the database that if you're working at Bob's and I go to buy a gun, or Sportsman's and I go to buy a gun, they're going to look at my name and my demographics and compare it to this NICS database. And if I've had one of those qualifying events, a prior commitment, it's going to be a flag go up. Then you notify the local police authority, so Drew just came in to buy a gun. So Chief Huda was notified by Bob's, this person came in to try to buy a gun. Her name was flagged. We warned you. Chief Huda picked up the phone and said, Drew, let's talk about this person. And this person was extremely well known. And he goes, can you get boots on the ground and go talk and figure out what's going on? And sure enough, we had found out that the person had an insurance change, loss of her ability to pay for medications, was becoming more psychotic. So we were able to make an intervention and return her to a level where she understood the dangers she presented when she was not medicated. That's a beautiful example of reasonably available information. Joe's team doesn't have that NICS database access, but law enforcement does for him.
So you said a lot of very interesting things in that statement. So you're telling me we currently have a system whereby somebody who has been entered into the database nationally, when they go to purchase a gun, it pops up that this person has a qualifying event, and then we have the opportunity to stop them from buying a gun.
Yes, there is a federal code that oversees it. I disagree with the language in the federal code. The federal code in these circumstances refers to the patient as a quote, mental defective. I don't like that terminology. It's time to change it. But that is the terminology for a commitment qualifying event. And because of that, every state, when they have a commitment order from a judge, the clerk enters that into the database, and at midnight it transfers over and it's entered within, I think, 48 hours into the larger NICS database. And that is something that is accessible by all law enforcement entities.
Wow. I find that very interesting because the people who are anti-gun continue to pitch this notion that we have to have all these things to prevent people from buying a gun. And as a gun owner myself, it's not easy to buy a gun even when you're not mentally deficient. And I did not know that we already have a program in existence that prevents that from happening.
Yes, sir, we do. It helps prevent that from happening. Again, as a gun owner, if we follow the legal guidelines to obtain the gun.
Okay, we run a little bit past our hour, but I thought it was interesting. Go ahead. I don't want to deny anybody questions. We just are, I'm letting you know we're running past.
Jennifer Leach with WSU Extension. This is great information, and thank you to the Board of Health to inviting Great Rivers BHO. And Drew, I think I've been around a little bit longer than you, but anyway, it's good to see you. And it's just wonderful, the history that has come forth. And, but a couple questions from a prevention side is actually just a little bit of background. Extension, we have a local person as part of a statewide grant on suicide prevention related to ag workers, Debbie Fredericks. So, but she offered a QPR training to 4-H leaders, and so I went through it a couple weeks ago. So, but what it reminded me is many years ago, and I'm going to give the question to Drew, are there any agencies currently doing QPR training?
To my knowledge, there are a lot of individuals being trained in it, but not a lot of entities providing the question per se, persuade, prefer training. It is a wonderful training. Most entities are combining it with what's called the behavioral health first aid treatment model.
Okay.
But none specifically just doing that.
Okay. And then the other question to Drew is, I know many years ago we did the 5 for Life. Do you remember that? So is 5 for Life and QPR and mental health first aid training, they're not the same, is that correct?
No, exactly. 5 for Life is something that I created years ago when I was in graduate school. And we put that in the schools, and we still do that within our middle and high schools in our community.
Great, thank you. And I think kudos to the commissioners from many years ago, as we used to have what was called a Regional Support Network, RSN, and somehow the law changed or whatever. So Carlos Carrion, who used to be department head for Health and Human Services for the county, he was really behind it. We formed Great Rivers BHO and focus on the counties we're focused on rather than counties to the south, knowing that the current counties served by the Great Rivers BHO have a different need than our southern urban counties. So anyway, I think kudos to the past. So again, I was on, actually, we used to have a SAB board, Substance Abuse Advisory Board, run by Carl Erickson. And then we had a Mental Health Advisory Board and within Health and Human Services, and we had a Disability Board and a Public Health Board, and then it was all combined to within Health and Human Services as a health advisory board. So, you know, I guess where I'm going with this is great information, and I'm hoping that that the PowerPoint will be shared so I can share it with the folks I work with, and great presentation. So thank you, the Commissioners and Board of Health for inviting for Great Rivers BHO.
Well, and that's Commissioner, kudos to him for inviting them back. I think this is the kind of Board of Health meeting that we all would like to see moving forward, spreading this type of information and being able to make better decisions for our community.
Worthwhile discussion.
Okay.
All right, well, thank you so much.
No, we
your time.
appreciate you guys taking the time and visiting with us. If the audience feels like we do and want to support the Regional 988 being down here, get with them and get the letter and put that in, because I think that's a good thing for us. And, other than that, thank you again. And
You're
we
welcome.
will
Thank
adjourn.
you.
Thank you.
Thank you.